Tufan, I'm confident that we share some experience with the increasing complexity of the patients that are presenting into our practices. I mean, in general, what's the current landscape for the female patients presenting to your clinic for evaluation and management of stress urinary incontinence?
Yeah, thank you very much, Melissa. I'm working in a very busy clinic in a referral center, in a university center. So the majority of my patients who I see are referrals. They have different urinary incontinence types, and also prolapse, and also painful bladder syndrome and interstitial cystitis complex. So there's actually a very wide spectrum of female urology that I'm dealing with. And of course, stress urinary incontinence is one of the major reasons of the referral in my clinic.
You know, I as well often care for patients with very complex incontinence, but I find that one of the most burdensome populations with regards to patient symptoms is those that are coming in with like recurrent or persistent incontinence after undergoing prior surgical interventions. You know, stress incontinence really, we've all learned to appreciate, has an enormous impact on a woman's quality of life. And that gamut ranges from increased risk of depression, anxiety. They oftentimes will tell me they've reduced their physical activity, which then propagates into increasing obesity, a lot of negative impacts on their productivity at work, their ability to maintain like healthy sexual relationships, and overall just a really substantial reduction in their day-to-day functioning. And these patients with really persistent or recurrent incontinence following surgery have an additional stress because there's really limited options for their condition that hasn't responded to what we all consider a gold standard of stress incontinence treatment. You know, and for this type of patient, you know, I have the 63-year-old, same story, persistent incontinence after mid-urethral sling. She has a component of stress and urgency leakage, but, you know, on my exam, I was able to clearly demonstrate stress urinary incontinence. Like, how do you proceed with counseling her? As, you know, our guidelines seem fairly clear about which intervention she can move forward with, but what would you do with that patient in your practice?
So this is a 63-year-old lady with mixed type urinary incontinence. Did she have any previous surgery?
Yeah, she had a mid-urethral sling probably 7 years ago.
Yeah, so I mean, she has more than one complicating factor here. The first one is a previous surgery. This is a failed mid-urethral sling, and the other one is her mixed urinary incontinence. She certainly needs a very thorough clinical evaluation, including a very careful history, a very careful physical examination, evaluation of all the comorbidities like you mentioned. And also in my practice, she is, of course, a very good, a must candidate for a full urodynamic study, including a cystometrogram and a pressure flow study. If a video urodynamic, let's say, tool is available, I would certainly go for a video urodynamic study in this lady.
You know, I have a very similar practice in that the way I tend to think about this is if this was my family member, I would want a physician that would use all the tools that were available to them to ensure an appropriate diagnosis before treatment. I mean, you don't want to proverbially throw things at a wall to see which treatment strategy sticks. And when we think about expanding like evidence-based medicine, urodynamics to me is such an important data point that's going to drive my interventions. There's so much information that patients have access to online, so they are more sophisticated than ever when they're seeking knowledge of their conditions. So we often will employ urodynamics as a way to engage the patient in their own treatment and recovery. And when they have that baseline knowledge, when we've explained the true dysfunctions that are happening, they gravitate even more to adherence to our treatment strategies. I believe that it really increases their health literacy, and it is a tool that helps me correlate for the patient their symptoms along with expectations of treatment.
Exactly, Melissa. I mean, many times we underestimate the wish of the patient, knowing her real pathophysiological mechanism behind her urinary symptoms. When I have a result of the urodynamic study in my hand, certainly the patient counseling, the preoperative patient counseling will change. I will be more precise in describing to my patient the mechanism of her symptoms and how precisely the treatment procedure that we are advising for her will act. So this is important. And actually, patients would like to know that. And this is I think, one of the basic rules of medicine, to understand and also to explain the mechanism behind the disease and do not behave unprickly unless you have to. Of course, there are certain conditions where you have to behave unprickly, but I don't think female stress urinary incontinence is one of these conditions, because we have in our hands a gold standard evaluation technique or tool. According to many physicians, it is the reflex hammer of the urologist. So we also know that from more than 50 years ago, as Bates and Associates have said, the urinary bladder is an unreliable witness. So we know that the urinary bladder can fool us in many times. The symptomatology enough will not lead us to the correct pathophysiology.
Well, to me, the urodynamics is my modern day stethoscope for urology. It's even more than a reflex hammer. And, you brought up an interesting point, and it's about our role as physicians. You and I work at academic centers, so we maybe have more of a role as a formal teacher, but all clinicians are here to impart information to patients about their condition. That's what they're relying on, is our knowledge base and our ability to siphon information and to create a clear picture of what's happening to them. And so a great deal of that information in my practice comes from those urodynamic studies that I can then reflect back to the patient as my learner. And I'm a teacher and they're the learners, and we are here to come together so they understand their condition, which only helps their healing.